moderate a panel this afternoon focused on hypomyelinating disorders, and in particular Pelizaeus-Merzbacher disease. We have 5 wonderful presenters who are going to walk us through different disorders, and in particular the promise of potential future therapies and platforms for developing therapy. The first speaker is Nicole Wolf. Dr. Wolf is a full professor of therapy at Amsterdam UNC, and her focus is treatment trials for hypomyelination and also for MLD, and she also works as a child neurologist at the Amsterdam Leukodystrophy Center. Nicole, do you want to get started and share your screen?
Yes, thank you so much, Adeline, and thanks to Ila for asking me to present here on hypomyelinating leukodystrophies and clinical presentation. Can you see my screen?
Yes, we can see your whole screen. So
my whole screen.
It's not yet in presenter mode. Yeah.
Yes. So one moment, please.
You might want to unshare because we can see your email behind it. You might want to unshare. Just a minute.
Not the best idea, I think. Stop share and again share. Yes, I think that's better now.
Now we see it exactly the right way. Thank you.
Thank you. So I apologize. I have quite a severe cold, so I probably switch off my video after my presentation. And if I'm coughing, please forgive me. My disclosures and now, I think many of you are familiar with the typical clinical presentation of a hypomyelinating leukodystrophy, the prototype of which is Pelizaeus-Merzbacher disease, or PMD, which is caused by variants of the PLP gene encoding the most abundant myelin protein. And that's a disease we've known for about almost 140 years, because it was described in 1885 in a beautiful description of the clinical presentation of a family of boys and men with a similar clinical presentation consisting of nystagmus, the pendular eye movements, usually from birth or several weeks after birth, wheelchair dependency, spasticity, mixed movement disorder, ataxia, coordination problems, intellectual disability, although that's clearly less severe than the motor impairment, and we all know patients with normal cognition. And it was always thought that those patients would have a greatly reduced life expectancy, although the first publication of Pelizaeus in 1885 already had patients in adulthood reaching 30 years and more of life. So the reduced life expectancy is relative and certainly depends on the severity of the presentation. And when I started my training more than 25 years ago, that was what everyone thought hypomyelinating disorders would look like. But we learned since that mild presentations are possible. First symptoms in adulthood are possible, meaning mild ataxia, mild spasticity, tremor, all slowly progressive, can start in adulthood. Severe presentations, including significant intellectual disability, are also possible. Severe epilepsy is possible, but not that frequent in this group of patients. And we have learned in the last years that transient phenotypes with normalization of both clinical presentation and the MRI abnormalities are possible, but in the whole group of hypomyelinating disorders, unfortunately, very rare. So when you look at those MRIs of children with hypomyelination, you see that they look very much alike. You see the whitish signal of the white matter, meaning that this is not properly myelinated on these MRI images. That signal here should be darker than the signal of these structures or the cerebral cortex. So it's way too high. And that's how hypomyelination looks like on the MRI. And when you see the corresponding clinical presentation, you see that this child is not able to have a head balance or to propel his own wheelchair. This child is walking with walking aids. This child actually is able to walk, although the gait is abnormal with balance problems. And this child actually is normal when even at neurological examination. So the whole spectrum is possible in hypomyelinating disorders, although, to be honest, most patients we have are in this group, and completely normal children are very rare. Epilepsy is, of course, a problem we see in many patients with neurological disorders. It's also possible that children with hypomyelination develop epilepsy, but it's not so common. Patients with 4H leukodystrophy can develop epilepsy, especially the patients we know without hypomyelination on MRI scan. Patients with hypomyelination and congenital cataracts can develop epilepsy, especially with fever. And epilepsy is certainly a very prominent feature in a disease called Pelizaeus-Merzbacher disease, which we always thought looks very much like Pelizaeus-Merzbacher disease, but it's caused by other genetic defects. Clinical course in many patients is usually stable until early teens. Sometimes this stable period is shorter, sometimes it's longer. But then we see in many patients, not in all, but in many patients, a slow deterioration. And that means increasing spasticity, ataxia, dystonia. If patients have been able to walk without support, they often get wheelchair bound in that period, first for longer distances and then permanently. Patients can develop problems swallowing. So patients who have already had a presentation without being able to walk, for example, but being able to eat on their own, are getting dependent on tube feeding. They often have a very slow intellectual decline, which is slower and milder than the motor decline, but it's often also there. And what we often hear in our patients, especially teenagers and young adults, is fatigue, severe fatigue, which we don't find any other cause for when we do blood tests, for example. Other problems, depending on physical handicaps and on the severity of physical handicaps, are scoliosis and joint contractures or hip luxation. That's not specific for hypomyelination. That's something we see in all patients with, for example, wheelchair dependency and severe physical handicaps. So, and in parallel to that slow clinical deterioration, we see on MRI that patients also develop very slowly progressive volume loss of the brain. So brain tissue is getting lost. You see that the brain ventricles are getting a little bit larger, and the CSF spaces where the brain cerebrospinal fluid is sitting are getting also a bit larger. So that's what we see in the patients as they get older. There are also non-neurological manifestations in hypomyelinating leukodystrophies, and some of them are really very problematic for daily life. One problem is a bladder function problem. Patients can have a hyperactive bladder, and that's common in patients with mild spasticity, and especially common in carrier women for PLP1 mutations, so mothers of children with Pelizaeus-Merzbacher disease. So that leads to urinary incontinence, relapsing urine infections, bladder infections, and so on. And that's something we usually ask for in these patients, but it's often also something patients have had for a long time and never thought of mentioning that because they didn't make the connection between the disease in their son and the bladder problems. So it's something we can partly treat. We can certainly improve medications, but it's important that we now know about it. Bladder problems are very early and very severe in one group of patients, and that's patients having a rare hypomyelinating leukodystrophy, which is called oculodentodigital dysplasia, or ODDD. And that often needs active management, for example, self-catheterization several times a day, because those patients have a very small bladder volume and from early life problems. Those problems can also start in adulthood. And that's actually one of the hypomyelinating leukodystrophies where we have regularly adult patients with first neurological symptoms, and also when we make the diagnosis first in adults. Dental problems are also common in some hypomyelinating leukodystrophies. In 4H leukodystrophy, it's even part of the name. Hypodontia is one of the 4Hs. You see here the typical tooth abnormalities in a young child with 4H leukodystrophy, with the delayed or even absent eruption of the median, upper median incisors. And here also the lateral incisor, maxillary incisor, is not yet erupted. Small teeth can happen in 4H, and also patients are prone to tooth decay. All symptoms are also possible in oculodentodigital dysplasia, although the hypodontia is not that typical as it is in 4H. Dysmorphic signs are rare, but in oculodentodigital dysplasia, you can have this very typical syndactyly. ODDD is a disorder which is transmitted from parents to children, and parents don't need, father or mother doesn't need to have syndactyly, but the child may have a syndactyly. So that's not the same in all patients in one family. There's one other leukodystrophy which has dysmorphic signs, which is called hypomyelination with spondyloepimetaphyseal dysplasia, where you have abnormalities of the shafts of the bones. And you see that children can have very short and a bit plump, a bit thick hands. And they also have abnormalities of their spine. They're often very, very short. Children with 4H leukodystrophy can also develop bone abnormalities, especially congenital hip dislocation, but also osteosclerosis, which means too much mineralized bones. And we think that has also to do with hypodontia, but we haven't yet understood that well. Some children with the 4H leukodystrophy also have facial dysmorphisms. That's relatively rare. There are leukodystrophies which involve also the immune system. Children with 4H leukodystrophy can be susceptible to varicella, chickenpox, and patients with relatively recently described leukodystrophy with this complicated gene name. It doesn't have any other name for the moment, can also have problems with the immune system, and they are prone to infections. Actually, that disease also has a very distinct gastroenterological involvement of the intestines. Patients can have early onset inflammatory bowel disease, which can have its start really at the very beginning of life with congenital diarrhea or very early inflammatory bowel disease. It also can start later in life, in early adulthood or teenage years, and it's difficult to treat in these children. And the protein affected, which is called PI4KA, sits actually in a complex with this protein, which is affected in another hypomyelinating leukodystrophy, which doesn't actually have those bowel abnormalities. So this is something very intriguing. But the most important thing is that in children with this leukodystrophy, we have to be aware that diarrhea can mean inflammatory bowel disease, and we have to treat those children accordingly. Eye involvement can mean a myopia, or excuse me, secondary problems of myopia in 4H leukodystrophy. These children have typically high myopia, which means thick glasses, minus 10, minus 18. I have patients with this a high myopia. And because in myopia, your eyeball gets longer, the risk of a retinal detachment is considerable when children get older. So this is also something to be aware of. I have several patients with 4H leukodystrophy who have had retinal detachment. Children with this leukodystrophy, hypomyelination and congenital cataract, can have congenital cataract, as the name already says. And it's important to think in children with this disease, with congenital cataract, that this is one of the differential diagnoses. And last but not least, a very treatable complication in hypomyelinating leukodystrophies is the endocrine involvement. And that's very typical for 4H leukodystrophy, especially the delayed or absent puberty development due to central problems of hormone control, which we call hypogonadotropic hypogonadism. But those patients can also have growth hormone deficiency, and that's not so frequent, but still can happen, central hypothyroidism. So we have a lot of different hypomyelinating leukodystrophies. Severity in those leukodystrophies is very variable. It depends on the affected gene. It depends also on the mutation in the gene. And quite often we also don't know and don't understand so well why some children are affected so severely and others have not so many problems. Most patients have a slow deterioration from adolescence in many hypomyelinating disorders, and there are a lot of extra neurological complications you have to think about when you see patients with hypomyelinating leukodystrophies. For treatment, you of course need different approaches for different disorders, for different disease stages, and also for different manifestations. And here I would like to stop. That's our center. And thank you very much for your attention.
Nicole, thank you so much. That was a beautiful talk. I always learn something new when you speak about hypomyelinating disorder. So thank you, and I hope you feel better soon. Thank you for giving the talk despite your cold. The next speaker is Dr. Sunetra Sase. Dr. Sunetra Sase is a research associate at the Children's Hospital of Philadelphia, and her work is in developing models of different leukodystrophies in order to look at therapies, and she's going to talk to us about therapeutic suppression for HABC or TUBB4A associated leukodystrophy.
Hi, I'm sharing my screen.
Not yet. Yes.
Can you see my screen?
Mm-hmm. It's not yet in presenter mode.
Yes.
Now?
Now?
There you go. Perfect.
Thank you, Adeline. And thank you, Ella Foundation, for giving me opportunity to talk here. Uh, as Dr. Vanderver mentioned, I'm research associate in her lab, and I'm going to talk about how TUBB4A suppression rescues HABC leukodystrophy. It's a hypomyelinating leukodystrophy, and Dr. Wolf did a great job explaining the hypomyelinating leukodystrophies. And so therefore, I have outlined my presentation where I'm going to introduce, then going to talk about how what are the models we have developed for the TUBB4A associated leukodystrophies, disease pathology in these models, and then the treatment approach which we have developed. So as you saw, like how this, or you heard from Dr. Wolf, how hypomyelinating leukodystrophies are causing the deficits, and it is important to understand how this myelin is formed. And this myelin actually is solely produced by oligodendrocytes in the brain, and they undergo dynamic processes starting from oligodendrocyte precursor cells to myelin forming oligodendrocytes, which wrap this myelin around the axon. And these myelins are essential. If you can see here, the neurons and the brain is like continuously working, and there is firing going on. And this firing is smooth, is occurs smoothly because of the myelin, and it preserves the strength of the electrical messages as it travels in the brain. So as I'm talking about this hypomyelinating leukodystrophy, it's important to emphasize that in most of the leukodystrophies, the myelin is disrupted, is primary or secondary. And in TUBB4A associated leukodystrophy, we also have a myelin disruption because of the mutation in gene beta tubulin 4A, which encodes the protein TUBB4A. So this beta tubulin dimerizes with alpha tubulin to form microtubules, which I have shown here on the right side, which forms which are important cytoskeletal proteins in our cells. And this beta tubulin component, which is TUBB4A, is highly expressed in oligodendrocytes, which are again myelin-producing cells, and also in some of the neurons of basal ganglia and cerebellum. And to give the importance of microtubules, because since I'm going to talk about TUBB4A-associated leukodystrophy, they provide rigidity to the cell. They assist the movement of organelles, and these are microtubules again form the cytoskeletal structure. They are highly dynamic, where they grow and shrink. And this process is important for transporting this organelles. If you can see here, the video which depicts how the microtubules are organized and how this motor protein is transporting different vesicles and cargoes on this bridge. And this necessarily is important for the myelin formation and also like wrapping the myelin around this axons. And the way I see them is like the multiple bridges in the cell. So if you see here, it's very obvious, like on the bridge here where the cars are going fast, where the traffic is jammed because they are not able to like go uh, on. And this is something which is happening in here where, because the bridges are not functional, the cargoes are not transported in the cells, which causes this hypomyelinating leukodystrophy, which is TUBB4A associated leukodystrophy. More than 30 different pathogenic variants are known, and it's a broad spectrum disease. Some patients have dystonia, dystonia. Some patients have isolated hypomyelination, and it's also pediatric patients who have presence with infantile encephalopathy. And today I'm going to talk about hypomyelination with atrophy of basal ganglia and cerebellum, which is TUBB4A associated leukodystrophy. In HABC, there are again different pathogenic variants known. But D49 here, which is shown here in the beta tubulin, is a recurring variant in this patient population. It's suspected to cause toxic gain of function. That means protein, when mutant protein is present, it causes the toxicity and is not functional enough and disrupts the microtubule function. It typically begins in early childhood. Kids have dystonia, ataxia, and the motor function is progressive, such that they lose the ambulation before the end of their first decade of their life. As they are associated with the myelin loss and progressive striatal and cerebellar atrophy. And here are the images, and which shows the hypomyelination and the basal ganglia atrophy and as well as cerebral atrophy here on by the thick arrow. So as there are no treatment approaches available, our lab uh, like modeled the disease first in the mouse, where we inserted this D49, which is a common variant in the mouse, as well as we have like iPSC derived cells. But in interest of time, I'm just going to talk how we have used this mouse model to develop the treatment for this HABC leukodystrophy, which could be also applicable for other TUBB4A-associated leukodystrophy. So for this, what we did is we had series of mouse models. So this mouse model has only one copy of mutation, and this plus indicates that the other TUBB4 is normal. We try to play with the dosages of the mutations, where we cross this to create the double mutant, which has high dosage of mutation, or its both copies are mutated. We also created the knockout, where there is TUBB4 is deleted, and then we cross the D249 and knockout to adjust the dosing, where we have one copy of mutant versus we don't have any TUBB4A. So we generated this model and then we studied them across after they are born. So the P0 is postnatal day 0, and then these are different ages. So the mice like eventually for this um, double mutant mice, the phenotype started from early on, like around P9 to P10 or postnatal day 9 to day 10, and they got severe over time where they had ataxia, dystonia, and seizures around their end stage, and we had to euthanize because they were not able to eat or walk or function properly. So similarly, in D49 and knockout, we saw similar disease progression as this, but slower. So we had disease starting around P17 to 18, and then it got severe. We measured all of this using this rotor, which is a motor function paradigm, where what we do is we this rod is moving, it's moving with a high speed. So if the motor function is weak, mice are not able to perform and they drop early, which is what happening in this double mutant, where they fall early and we record this in latency in seconds. And then this D49 and knockout perform poor as they progress towards their end stage. But importantly, the knockout are performing same as wild type, and this like and even the D49N, which has like a less like a less dosage, is also performing as equal to the wild type. So this suggests that the knockout, importantly, is uh, performing well, and the gene function may not be like, yes, it is important, but at this point, there may be compensation occurring, which I'm going to talk shortly. So this was about the behavioral phenotypes. Like we do see some of the behavioral phenotypes which are seen in affected patients. Then we checked like what happens in the brain. And for that, first we did the myelin staining. And for myelin staining, we use this idiochrome staining. And these are the mouse sections where what we did is we stained them, and this blue is myelin. And if you can see in wild type knockout and even in this heterozygous mice, you can see the blue stain. Very nice. But it's absent as the mutation dosage increases, where it's very severe. And we also did high electron microscopy where we can see myelin at the ultrastructure level. You can see this is myelin wrapped around the axons, and at that myelin which we have plotted here also was reduced in the mutants in D49 in knockout and double mutants. So, which is in apogee ratio is inversely proportional and see that. So this mouse model also recapitulates the myelin deficits, but the knockout again is performing as equivalent to wild type. Then, as we know that, as I mentioned, the oligodendrocytes are myelin-producing cells. So we saw what happens with these oligodendrocytes, and we can stain them using like different markers. And we used ASPA, which is a mature oligodendrocyte marker, and we counted at different ages. Hello, counted at different ages, and we can see that in corpus callosum, at different ages, the oligodendrocytes were also produced, which are main myelin-producing cells. Then the second part of the disease is cerebral atrophy. So we checked if similar effects are seen in mouse models too. And then we use the NUN to stain the neuronal cells in the cerebellum, and then the cascades to see if there is any cell death occurring in all these different models. And we can see that the neuronal population is, or these are specifically cerebellar granule neurons, which are reduced in both the models as compared to controls, and there was increased cell death also, which we notably saw in both of like this models. So this like is very important in the sense that the disease model recapitulates the disease, and the knockout doesn't show any phenotype. And the question is like, why knockouts are normal? So what is happening here is like, this is wild type microtubules. They're able to form. They are able to perform their dynamic function where they grow and shrink. But in presence of mutation, there is slowed growth, and they are not as dynamic as we want them to be to able to function all those organelle transfer, which is important for the myelin formation. But in absence of TUBB4A, what happens is other tubulins come and do their function. So microtubules are able to form and the bridge, and then they are able to perform well. So that's why this knockout is important, and I'm going to emphasize why. So to summarize my first part, that this mouse model recapitulates deficits like behavior, myelin, and in neurons. And then this mutation is toxic gain of function, and importantly, a lot of time I was emphasizing on knockout because that then can be used as a treatment approach for HABC as well as general TUBB4A associated leukodystrophy. So our next question was like, would this, like if we knock it down therapeutically, can we rescue the disease? And for doing that, we used this compound head model, which had like a longer survival period time. And we can do this by different methods, antisense oligonucleotides or AAV gene therapy. And we used antisense oligonucleotides. So I'm going to quickly describe what are those. So in the cell, DNA is converted into mRNA, which is the transcription process, and then mRNA are translated into proteins. Then, in a disease state, we have mutated mRNA, toxic protein in case of our disease, and especially in TUBB4A associated leukodystrophy. And what is happening? We design this antisense, which are 18 to 19 molecules, 18 to 19 base pair, which bind to this mRNA. mRNA is degraded, and the protein production is reduced. So, we're using this strategy, and we are reducing the TUBB4A protein in here, or sorry, TUBB4A RNA and then protein. So what we did is we almost screened 100 to 150 molecules of all these ASOs on the cells. And we chose that ASO which provided more than 90% of TUBB4A downregulation in the cells. Then we moved them into the mouse. We injected directly in the brain after they are born around P1, and we also recorded TUBB4A reduction. And first, I'm going to talk about the safety, where we did rotarod to check which there are any deficits. And I'm just showing rotarod, but based on the rotarod, we chose this 18-3 molecule to go ahead and see if it downregulates in the mouse. So again, the similar experiment, we injected in wild type mice at the age of P1, collected the tissue and measured RNA and protein. And this is just the RNA in cortex and the striatum, which are the brain regions. And we found that at least by 20 to 15 microgram of dose, we get more than 50% of reduction. So then as we have like a good reduction in cortex and striatum, we took this molecule and then we injected it in the HABC mouse model. So for the study design, we injected again early on, as we want to target the pediatric population data. And then we observed like over year what happens. So excitedly, we did see threefold increase in survival. So originally, mice were dying at P110 or P108 to 10, and then they were surviving till almost P362 to 365. So next, during this time, we also recorded the behavior because yes, we know that the survival is improved, but what happens the behavior? So again, we did like a rotarod, which is a motor function test, which I described shortly. So if you see, these are the disease mice, and these are over it, like over their age, and they perform weak, and they of course die around P110, but then this treated mice do very well. But then again, by the time they go, they do join the disease trajectory. And this is just with the single injections that we have so much improvement in the motor function. Then we have also much improvement in other behavioral tests like four-limb grip strength, where what we do is we use this machine to measure the grip of the mice. And we do see also improvement in the grip strength of these mice with the treatment. So next we check like what happens with the myelin. So if you so we definitely saw the increased myelin levels in the treated mice. So these are control, and in untreated mice you see here that the myelin is thin, and versus in ASO treated, there are the myelin is prevented or myelin loss is prevented. Of course, it's not perfect there, but it's still like very good and compared to like untreated, which we have plotted here where we measured unmyelinated person unmyelinated axons, which are like much more improved in the treated. We also measured like the myelin vacuoles, which were like more here, which we have marked with a star. And then we did see a drastic improvement. And another point is like the myelin stayed intact till P110. We the data which I have not shown is like we also did some of the data at the later point, and we do see some myelin deterioration, but as compared to wild types, and like later at P103 close to their end stage, but it's not as bad. But this treatment was very effective in rescuing the myelin deficit. Now, next, what we did is we checked if the myelin is functional, and for that, we used the evoked potentials, measured in vivo evoked potentials. So, what we did for that is we did do the surgery on mice and place the electrodes to measure the action potential of the neurons, because that's how we can measure how if the neurons are functional because the myelin is retained. And if you see this blue here are untreated mice, and they perform like very like have a larger latencies as compared to the control. And the pink here are treated where they don't get as better as control, because if you see the control P2 latency is like shorter, but in here in the treatment it does improve, which is plotted here. So this summarizes that the ASO treatment rescues the HABC phenotype in the model and improves survival. It could be a viable treatment approach. One of the limitations or the data which I have not shown is we were not able to target the cerebellar granule neuron through this route, and which we are still working. So how we can address to get those results. And yes, it's still long to go into the clinical trial, but it's very, I think it's fascinating to see that the treatment like works. So with this, I would really like to thank Dr. Vanderver, who gave me an opportunity to work on this project, and also like all the team members, collaborators, and importantly, HABC Foundation, as well as the Synaptics Bio company, which is formed from the HABC Foundation, who have funded this project and who supported a lot to get this project going. Thank you.
Thank you, Sunetra. That was lovely. We're gonna do all questions at the end, so we'll move forward into the presentation of Steffi Dreha-Kulaczewki. Dr. Dreha comes from the University Medical Center at Göttingen and the pediatric and adolescent clinic there. She has a long-standing expertise in different hypomyelination dystrophies and is going to speak to us about natural history and an antisense, just keeping in the same theme as antisense therapy, an antisense therapy for Pelizaeus-Merzbacher disease, which is sort of further along and already in clinic. Steffi, are you?
Yes, I'm actually ready, and I'm going to share my screen.
Perfect. I'll let you know when we see it because it can be hard to tell.
Is that all right?
Yeah, we don't yet see presenter mode. Yes, now it's perfect. Thank you.
Perfect. Okay, thank you.
Perfect.
Well, thank you very much for the invitation. My name is, and for the introduction, Adeline. My name is Steffi Dreha-Kulaczewki. I'm a pediatric neurologist taking care of patients with leukodystrophies. And I'm quite excited to present some of our experiences of two, let's say, adjacent trials. One is a natural history trial, one is back-to-back, leading into a phase 1 clinical trial for the validation of one of the potential therapy strategies for Pelizaeus-Merzbacher disease, which is an antisense oligonucleotide based therapy. And as we've heard a lot of about therapy options for ALD, it's quite exciting to say that, well, maybe for the PMD, there's another therapy looming at the horizon, but we are not there yet. We are actually at the phase of running a trial. And I would like to go through with you to some of the steps that is necessary in order to actually start a trial. This is called the trial readiness. And of course, for that, you need to discover the underlying biology and why that therapy strategy would actually work. Then the preparation, how is it all set up, getting an idea of what needs to be collected. Then the prerequisites for each site that you need to check in order to get initiated or participate in the trial. That means, is the stuff ready in terms of equipment? Is that all in place? And then I'd like to go through some challenges regarding the recruitment and some experiences from the side from us as clinicians, but nonetheless also for you as the clinical, as the patient side. And as a patient, from the patient side or family side. We all know that for the Pelizaeus-Merzbacher disease, at least in contrast to most of the other leukodystrophies, there are some genotype, phenotype correlations. We all are aware that in the families too, that the clinical spectrum of Pelizaeus-Merzbacher disease is quite extremely broad, as it is for many others, as we are getting aware of it. It ranges from the very severe congenital form, going through more moderate forms, and then to the very clinically more or less severe forms where there only are gait difficulties, and which is also called the spastic paraplegia type 2. And knowing that, going from these phenotypes, then it was sort of discovered that there are different variants in the mutation of them, or in the PLP gene that leads to these different clinical phenotypes. And we know that the point mutation, I'm getting to that in a little bit more details later, they can cause all sorts of clinical severity, but the most severe forms only have these point mutations, so they are probably much more prevalent in the more severe forms. And as we move on to the more moderate clinical courses, there we have the majority of the duplications. And then, interestingly enough, and I'd like you to remember that the less severe clinical forms, they do have a null mutation, which means that a null mutation. So the point mutation, they lead to proteins or the PLP1s that are wrongly shaped, they're misfolded, their 3D structure is not correct, so that the protein is misfolded or misshaped. The duplication that leads to an overexpression because the gene doses is enlarged, so the protein doses is enlarged, and it's an overexpression of too much of that PLP1. And interestingly enough, if you have less or no protein or no PLP1, then you have that less severe clinical phenotype. So having less protein apparently is, in terms of disease severity, advantageous and better. And as these clinical trial focuses for now on the duplication, I like to zoom in here into more details. We know that the duplication is, or that the PMD patients, the majority of the PMD patients have a duplication, as I said, more gene overproduction of PLP1, although the protein itself is in structure and in terms of structure and function intact. However, why that in too much of a protein, which is actually rightly structured, causes damage is not exactly clear, but there are some ways of damage are already elucidated, and one is that the transport of these protein out of the oligodendrocytes is impaired if there's too much, and they form complexes with cholesterol, for instance. All that is clogging the transport ways out of the oligodendrocytes. So all that accumulates in the oligodendrocytes, and if there is something accumulating in the cell that should not be there, that's definitely causing damage to the cell. So there's loss of oligodendrocytes, and then if there's first no PLP1, does not reach this location where it's needed for myelination, then there is a deficiency of PLP1 during myelination, and then there's a deficiency of myelination, so a hypomyelination. And loss of oligodendrocytes means the cells who are actually building the myelin, they are dying or they are damaged and they are reduced in their numbers. So going back, or as there are many families here, I'd like to go to Biology 101 and just really in a nutshell saying that our genes and even the PLP1 gene is encoded in our DNA. So the DNA represents the blueprint of our let's say structures of our cells, because the DNA encodes the proteins, or how the proteins are built. And that encoding, or that cookbook, so to speak, that recipe needs to get out into the cell in order to actually build the proteins according to the cookbook. And that is done using that molecule that is called messenger RNA, so ribonucleic acid messenger RNA. These are the ones that carry out the copy of the genes that is in the cell nucleus out of it, and then there can the proteins being synthesized according to this copy. So what happens, or that what is the basic of these antisense oligonucleotides is that, as you can see here, you have your DNA, and then you have that copy, the mRNA copies parts of that, parts of the genes. And then when you know what your mRNA looks like, and this is what I said, you need to know the biology, then you can create or produce in the lab another molecule or another parts of the protein that is the exact opposite of that mRNA from the gene, from the copy of the gene. And these two, they create a RNA or ASO duplex or a complex, and that complex is recognized by enzymes to say this is wrongly shaped and we're going to get rid of that. So they cleave that RNA ASO complex, And all these pieces that are left over, they are without any function, so they are, degraded and are being carried out of the cell. But there's no protein synthesis, hence there's no production of the PLP1 if we focus again on the Pelizaeus-Merzbacher. And these ASO therapy, we know that is sort of getting more and more prevalent as a therapy regime or as a therapy principle, because you can play around with these ASOs when you know your biology. So depending on the design, you can actually just not alter, you can alter different types or different pieces of these mRNA, and with that, not just depleting the protein synthesis or stopping protein synthesis, but maybe change the protein structures, and you can, depending on how much, depending on the doses, you can very nicely and very fine steps guide or guide the effect of that therapy. However, and that is also true for the Pelizaeus-Merzbacher, it's a treatment, but it's not, as it is not gene therapy, or so it's not a cure. And that what made that ASO feasible for the PMD and then sort of started the all these actions to get that trial running was this seminal paper from 2020, where they could show, by the group of Paul Teaser, could show that in a PMP mouse model, the PLP1 expression, or the amount of the PLP1, could be suppressed by that ASO they developed. So they took the Gimpy mice, which is this mouse model with very severe symptoms, and injected into this CSF of that mice these PLP1 specific ASO, as I described to you just before, and they could see quite an astounding effect, because these mice, they had an improved myelination, they had an increased number of oligodendrocytes, they had an expansion of their lifespan, and altogether their symptoms were less severe. They were not quite symptoms-free, but they were less severe. And all of that together led to the setup, or the trial readiness, so to speak, to the setup of actually starting that trial. And this PMD program was started by the company called Ionis, and Ionis had a lot of experiences with ASO because they started also the Spinraza therapy in spinal muscular atrophy. So what do you need to do in order to actually get then a trial ready and running? And we all know, and those who have been involved, they know that it started actually years ago during Corona, really, with lots of initial calls, online meetings, and Zoom meetings. And there were quite, let's say, fruitful discussions between us as medical experts and those who are actually running the trial and the sponsors. And we first started off setting up parameters, so what needs to be measured in order to actually have a readout of if that therapy is affected or not. And these parameters have to be as specific as possible for Pelizaeus-Merzbacher. So in the end, as you can probably imagine, it's not one parameter, but it's a whole matrix of different parameters set up in order to evaluate therapy effects, yes or no. And of course, there need to be biomarkers, as I said, suitable to actually measure some effects. And as a local facility, you go back and check, is your clinic actually equipped with all of it to start such a trial? So are all the investigations doable for you? And the key part, of course, is you have to build your team. So the team has it's a multidisciplinary team. They have to have the necessary qualifications, and they need to take courses for good clinical practice and or other prerequisites, they need to be, you know, motivated to put that extra time in, and usually it is extra time, and they need to check if the equipment is available, like do you have the appropriate MR scanner, which probably needs to be a 3T, and is it all accessible, and who can sort of make slots available for maybe multiple runs of one investigation if it didn't work on the first time. So the center of it all are the study coordinators and study nurses, because they manage the patient contact and the timing and the schedule, which is in a clinical trial or in a natural history trial, both very important. And though for those of you who have already maybe participated in a trial, they know that once you are, you know, recruited, once you're started, you are, you know, giving up some of your freedom, because then you have to follow that really strict schedule, and there are maybe a week or two of flexibility, but it has to be in that interval. You have to come to the hospital, or you have to have a phone interview, or have to fill out some questionnaires, etc. And there's not much flexibility actually. And the study coordinators, they are also handling the probes, taking them to centrifuges or back and forth between the labs. And I really don't want to go through all what is needed, especially for the natural history trial, for instance, but let me just point out the new radiologists, and I'm very inclined towards MRI. So they had to check, are they capable of implementing these special protocol, because the one of the parameters was not only the structural changes in terms of qualitative assessing, is myelination increasing, yes or no, but it's already some quantitative sequences that were part of the protocol. So to get an estimate of myelin in terms of numbers, for instance, and these special sequences, they needed to be implemented, and you have to have personnel who can do that. And all those were parts of the natural history trial, and having these two trials back to back, of course, is a special situation, because then switching to the clinical trial is not so much of a effort anymore, because you only need to add the pharmacists and the logistic for actually handling the agent or the medication, these specific ASO. So for the recruiting for our own site, of course, we could go back and check and talk to our own patient group. And then if that weren't enough, or if this is not enough, then you turn to the National Patients Association. This is where ELA comes into play, and I cannot stress enough the importance of that patient association, and even internationally, as we are here now together, but also the network of ELA Germany, because in the end, this is what you do. You pick up the phone and you call the person from ELA and say, we have that trial, we have the option of running that trial, do we have patients, and who do you know, and who can we contact? And they then go out and contact their patients or their peers in that ELA. So and otherwise, and then you go further and contact your nationwide network, or you need online posts and other flyers you hand out for recruitment. The inclusion criteria for that natural history study are, for both trials, are the duplication, as I said, that I was focusing on the duplication, and the age ranges for that natural history trial, which is now called the Rocket study, 6 months to 17 years, so a very broad age range. We want to include as many patients as possible. And then back to back as a new study, but really back to back is this ORBIT study, the clinical trial, which recruits patients between 2 and 17 years. And of course, there are many more inclusion criteria, and for that, I'd like you to refer to the clinicaltrial.gov site, for instance, where they are all listed in detail. So the natural history trial is where we started off, because with the goal that we want to assess changes in fluid biomarkers, let it be, CSF and blood, in neuroimaging and in the clinical symptoms, and last but not least, and very important, these patient and caregiver reporting outcome measures. So the natural evolution of the disease needs to be recorded or documented very carefully first, and then as a baseline for what does the ASO do, whether the ASO does something or not. And of course, many families were interested, as you might know, and some of them were quite disappointed about the inclusion criteria process. So that has to be a duplication. Couple of those were presenting with a point mutation. And then the language barrier was also problematic, as it was a prerequisite that it has to be the native language, and for us, German, the German language, that we need to make sure that the consent form is understood properly and without any, at least, major translation or translators. But the families we could recruit, they had, no objection, no major questions. They were all quite keen on starting. And they were quite well informed, actually. They went, as you all can do, to that clinicaltrial.gov website, or got their information from other sources and chat groups and all the contacts you are aware of. And the question we were facing weren't primarily about objectives and where that might lead and why it is so strict, the schedule, but more like how is it working? How do we get from A to B, the exact workflow and the processes of the sedation for the MRI and the LP, so more the practical ones. However, most frequently, and quite rightly so, I think, is that, of course, being in the natural trial is quite attractive in itself, but of course the prospect of recruitment into the clinical trial was one of the major motives for actually getting into the natural history trial. And we were, as PIs or as study sites, we were told by the sponsor that those who are in the natural history trial were prioritized for the recruitment of the clinical trial. However, no guarantee, and that is a very important point, that we cannot make any promises regarding that. And this is now, we are now recruiting for the clinical trial, and of course all our families from the natural history trial, they are waiting for slots. But as I said, there's no guarantee that there will be one. We cannot, and this is really hard from the clinician side, you cannot give a guarantee, you cannot assure them that they will be recruited, because the slots are given out per site from the sponsor, and then the slots depend on what cohort is currently recruiting and which cohort needs to be filled first, before you can move on to a different cohort. Might it be due to age or due to the dosage of the ASO? However, all the families, they had actually little apprehension against that concept of phase 1, and concept of phase 1 means it has never been tried in a person before. It's only there are enough safety data, and the FDA and also for us in Europe, the EMA was convinced by those safety profiles. However, the safety profile was only generated by animals, right? So it's not been tried in persons, but that was not for most of the patients or for most of the families, that was actually not a real problem. There were other questions, however, and these exact timing is one of the most prevalent questions, and luckily enough, once you start that trial, the schedule is fixed, because then you have to have week 1 and week 26 and week whatever 45 and 68, whatever, because then that timing is must be guiding your year or the 3 years of the next 3 years of your life. Some of the consent forms or some wording in the consent form was confusing. So we had with each of the families several Zoom calls in order to go through and answer question before they actually come in and for signing. And most importantly, there were 2 questions, and we could not quite answer them sufficiently, or cannot quite answer them sufficiently yet, saying that if the ASO shows a positive effect, what happens if the ASO application is stopped, which is part of the protocol, and then in the end of that study, after the ASO is stopped, there is an observation period, and during that observation period, the symptoms are reoccurring or getting worse again, what happens then? That was one very important question. And the other one is what happens after the end of the study, and both we could not quite answer yet sufficiently, but these observation period is one firm and fixed part of the protocol that will hardly be changed. And what happens after the end of the study, of course, that strongly depends on what the data are saying, and if that then is worthwhile continuing, which we do not know yet. So the phase 1 is all about safety. We actually do not as a first goal, look at effects. It's all about safety and how is it tolerated, what are the side effects, are there side effects, etc. And so it's safety and tolerability in 2 different or several different increasing doses, not per patient, but per cohort. And what I've learned, and probably many of my colleagues are not probably, but many of my colleagues are in those situations too, that we are asked what we are thinking and what we are hoping and what we are expecting, but we are not allowed to, or I should, as a clinician, really refrain from discussing my personal opinion, my personal expectations regarding the effects. So that is something I've learned in that process, really, to be hesitant about that. And for the clinical trial, we were happy enough, and for the other sites probably do have the same experiences with the preceding natural history study. For that, we have set up all the infrastructure already, so the transition into the clinical trial was pretty smooth so far. And what we learned, or what we have been asked, that feedback pipeline should be stronger with the families, saying, oh, have you heard of other sites? Or are we not allowed to say that, but about how was it going in your site? Were there any so having a closer contact if they have any question, that we get back and forth in really close contacts. And we, one of the special aspects of that clinical trial is that the ASO is introduced via or applied via in the CSF space. So we have to have repeated lumbar puncture. We need to have atraumatic needles. So these are a few details from the protocol. And this is the local team in Göttingen. I'm not going through all of those names, but without those, we would not be able to start or to be running that trial. And with that, I thank you for your attention, and I should be happy to take any questions after that session.
Thank you, Steffi. I think, again, we're going to take questions for anybody just joining us now. We're going to take questions at the end of all the talks. The next speaker is Dr. Kleopas Kleopa, who is coming to us as a professor and senior consultant neurologist at the Cyprus Institute of Neurology and Genetics. Dr. Kleopa is going to speak about the development of gene therapy for Pelizaeus-Merzbacher disease. Is I hope here. I saw him earlier.
Yes. Hi, Adeline. Thank you very much. Can you hear me?
I can hear you now. Perfect.
I just share my screen.
It's absolutely perfect.
Great.
We can see it, and I will put myself back on mute and let you share this talk with us.
Okay. Thank you very much. I would like to thank Ella for this kind invitation and for giving me the opportunity to present our research on gene therapy for PMLD1. This is a disease that we have been working on for many years, and before that we also worked on the molecular genetic mechanisms of the disease. So we have made some progress, but there is a lot of still way to go, as you will see, and we're definitely not at clinical trial readiness or even at planning clinical trials, as we have heard for the other disorders today. So just a brief introduction to Pelizaeus-Merzbacher disease type 1, PMLD1. This is a neonatal or early infantile onset type of hypomyelinating leukodystrophy. You heard Professor Wolf at the beginning. These children present with nystagmus, hypotonia, delayed motor milestones, and they gradually also develop spasticity, gait, and speech dysfunction, dysphagia, extrapyramidal symptoms, and orthopedic complications. They have typical MRI findings of hypomyelinating leukodystrophy with changes in the MRI, as you can see here, increased signal in the brain and cerebellar white matter, but also involvement of corticospinal tracts, brain atrophy, ventricular dilatation as the disease progresses, and there is characteristic preservation of the deep gray matter nuclei and the thalami. The disease is caused by mutations in the GJC2 or gap junction C2 or connexin 47 gene. This is an autosomal recessive disease, so patients have biallelic variants in this gene that encodes the gap junction protein connexin 47. And typically, parents will be carriers of this mutation, and children have inherited the mutation from both parents. PMLD1 accounts for about 10% of Pelizaeus-Merzbacher disease, and in consanguineous populations, this may go up to 30%. So it is clearly much more rare than Pelizaeus-Merzbacher disease itself. What does this gene do and the protein that it encodes for? This is a gap junction protein. These are type of proteins that form channels mediating communication between membranes and between different cells. in our body, here in the brain. So connexin 47 forms very important gap junction channels in oligodendrocytes in the central nervous system. It is present in all oligodendrocytes, which, as you know, are responsible for forming the myelin in the brain. So it mediates the connections between oligodendrocytes and other oligodendrocytes, as well as between oligodendrocytes and astrocytes, which are very important supporting cells in the brain. And as you can see from these diagrams, this gap junction network, it is quite widespread in the brain. It connects many cells with each other, especially oligodendrocytes and astrocytes, and we call this a gap junction network, which is very important for preservation of homeostasis, for transport of signaling molecules, of ions, of nutrients, of energy supply, and for maintenance of homeostasis in the brain. So in the case of the mutations in patients, we know now that after many studies that were done both in cell cultures, but also in animal models, that these mutations in PMLD1 patients cause loss of the gene function. So as you can see here in some early work done by Jennifer Orthman-Murphy et al., when you express the connexin 47 protein in cultured cells, it forms these little plaques on the surface. These are gap junction plaques. This is the normal protein. But when you express the mutated forms of the protein, these show retention within the inside of the cell. They don't reach the cell membrane. And as a consequence, they do not form any gap junction channels. And in this way, they also cannot function anymore as channels to mediate coupling and communication between cells. This mechanism has also been demonstrated in disease models in mice. So when you delete connexin 47 in mice, they do not develop a severe brain disease because they have compensatory activity of other similar protein in the brain, the connexin 32. But when you delete both gap junction proteins in oligodendrocytes in mice, they have severe leukodystrophy, which is progressive, leads to destruction of the myelin, vacuole formation in the brain, loss of oligodendrocytes, and early death in this model. And this is the model that we use to test treatments for this disease. Mutations that were found in patients were also expressed in mice, and this did not show any additional effect other than the loss of function. So they behaved in a similar way as the complete loss of the protein, supporting again the fact that the disease is caused by loss of the gene function. So based on this knowledge that has been gained over a decade, we developed a strategy to replace the connexin 47 gene in oligodendrocytes in order to treat the disease. So this work has been going on for the past 10 years. We initially used an adeno-associated viral vector 1/2 hybrid capsid that delivers the human connexin 47 gene. And in order to achieve a specific expression in oligodendrocytes, in other words, to make sure that our protein is only produced in the cells that need the protein and not in other cells, because this is a structural protein, we place the gene under the control of a cell-specific promoter. In this case, we call it MBP promoter or myelin basic protein promoter, which ensures that the gene we deliver is only expressed in oligodendrocytes. So initially, we delivered this gene therapy by direct injection into the brain. in the internal capsule of these mice. And when we delivered this vector expressing the connexin 47 in mice that were deficient for the protein, so they had no production of connexin 47 in their brain, we could demonstrate that we have again expression of connexin 47 specifically in oligodendrocytes, actually in a large percentage of oligodendrocytes. And this led also to improvement in the motor function, prolongation of the survival, and improvement of myelination in the model of the disease. And this was published already 8 years ago. So in the last 8 years, we have been trying to develop a more clinically translatable approach that will not require a direct injection into the brain. So in order to do that, we tested various strategies, including two of the currently leading AAV viral vector capsids that are used in clinical trials. For example, AAV9 is used for the spinal muscular atrophy treatment in the clinic, and AAVrh10 is also used in clinical trials for Krabbe and other disorders. And so we compared these two viral vectors, and in addition, we compared different injection methods. We used both intravenous delivery, so systemic delivery, as well as lumbar intrathecal delivery. And so we did the comparison of two capsids and two delivery methods, and we used both the therapeutic DNA plasmid, but also a reporter gene plasmid, the green fluorescent protein, to facilitate the readout. And I will show you very briefly what the outcome of this comparison was. When we injected intrathecally these vectors, we found that both in the brain and in the spinal cord, there was more efficacy of the AAV9 vector compared to AAVrh10. And the targeting of the brain was not as good as that for the spinal cord. So, and this has been shown in other clinical and also in preclinical studies. When you deliver the viral vector in the lumbar intrathecal area, you don't reach the brain as well. So that was the conclusion from the intrathecal comparison. And when we then use the intravenous injection, we found that this achieves a much better targeting of the brain as well as the spinal cord, and much more with AAV9 than with AAVrh10. And this is the comparison here. You see in the brain in blue bars, this is AAV9. This is the percentage of oligodendrocytes that have been targeted and express the transgene. And AAV9 is superior to AAV10 in all areas of the nervous system. We also evaluated the expression of connexin 47, which is the therapeutic gene, in mice that were deficient for this protein. And again, here we see the same results. We see that the intravenous delivery of AAV9 is the most effective to target the majority of oligodendrocytes, as opposed to either intrathecal or AAV10 approaches. So based on these results, we then proceeded with an intravenous treatment trial in the PMLD1 model. So again, to remind you, the model of the disease is the double knockout. So this is the mouse that is deficient for both major oligodendrocyte gap junction proteins. It has a very severe phenotype. So in this case, we deliver the gene therapies very early in the life of these animals at postnatal day 10, when they're 10 days old, in order to have a meaningful therapeutic effect. And so here we compare the therapeutic vector with the mock vector that only produces a reporter gene. And so we evaluate the outcomes at 30 days of age. You can see, first of all, here that, again, with this approach, we achieve a widespread targeting of oligodendrocytes indicated by the green fluorescence in various areas of the brain and in the spinal cord. We also, again, demonstrate that the expression in oligodendrocytes is specific, and so our DNA and our gene therapy does not express the protein in cells that should not be doing so, in neurons, astrocytes, and microglia. And this is important because here we cannot have a cross correction, first of all, so we have to correct the oligodendrocytes. And second, we cannot express the gene in the wrong cell type because that may have adverse effects. Here you see that we achieve widespread biodistribution of the vectors. So these are the vector genome copy numbers related to the animal genomes. And these are quite high throughout the CNS. Of course, there is some distribution of the vector in the peripheral organs, and we also have very high percentages of expression in oligodendrocytes in various areas of the brain. We did also demonstrate improvement in the function in these mice. We measured the motor behavior with various tests. One of them is the foot slip test. So we measure how many times the mouse will have a foot slip when walking on a mesh of a wire, you see here. And so the treated mouse is much more able to walk on the wires and not have a foot slip. In the Rotarod, they also have much better endurance. They can last more on the rotating rod. And also when we measure the way they walk, they have a much more stable and less unsteady gait. And we measure that with various footprints. We also show in this video that this is the mouse model of the disease. As you can see, it cannot move very well. It trembles. It's very slow and cannot climb. And this is the mouse after treatment. It is able to move much faster, climbs up the wall, does not have the tremor of the tail. So this is a clear improvement in the behavior. And we also have prolonged survival. This is the Kaplan-Meier curve. And we also have improvement in the myelin, as shown here by the staining for myelin in red fluorescence. This is the treated animal brain areas, and this is the mock-treated animal. We also showed improvement in myelination by quantifying the amount of myelin formation in the brain, in the corpus callosum, and in the internal capsules, so significantly increased myelin, and also in the spinal cord, in the anterior part of the spinal cord and in the posterior part, we see more myelin formation and also much less vacuoles, which are typical for this disease model. So in conclusion, we have shown that AV9 is effective when delivered intravenously, much more than AVRH10 and much better than when delivered intrathecally to provide a therapeutic benefit, at least in very young animals, and demonstrated that with various outcome measures in the model of the disease. So, and also to prolong survival. We have also performed a dose escalation study. So we used different doses of AV9 delivered intravenously and again examine the same outcome measures. This is in order to find the optimal dose that we can extrapolate in further clinical translation. We showed that there is a dose-dependent biodistribution of the vector. So the higher the dose delivered, the more targeting of the brain and spinal cord. We also see a dose-dependent expression of connexin 47 in oligodendrocytes. So the percentage of oligodendrocytes that are targeted in various brain areas, including the brainstem, corpus callosum, cerebellum, but also in the spinal cord, increases with increasing vector dose. We also performed the complete behavioral analysis. I'm not going to go into detail, but we see improvement in foot sleep test, again in the Rodarod and footprint test, which is dose dependent. So it is best with increasing dose. And we also have improvement in the morphology, again, measured in the same way, the amount of myelin formed in the brain areas and in the spinal cord. We see in the treated animals improved myelination as opposed to the mock-treated disease model, and in some areas similar to the normal mouse shown here as a control. We also examined inflammation, which is a pathological characteristic in this model and likely also occurs in patients. As with other forms of leukodystrophy, myelin damage brings also inflammation, activation of astrocytes, activation of microglia. And so we can measure this in the disease model. And we showed in the dose escalation study that we have, with increasing dose of the vector, improvement in the inflammation, much less astrogliosis and much less activation of inflammatory microglia in the brain and in the spinal cord. So concluding from the work we have done so far with the intravenous delivery, we have shown a dose-dependent biodistribution of AV9, driving the expression of the human connexin 47 gene under the control of the myelin basic protein promoter, at least when delivered in young mice at postnatal day 10. The expression is specific in oligodendrocytes throughout the central nervous system. We achieve improvement in the behavioral performance, improvement in the myelin, and improvement in the inflammation in this model. So where do we currently stand with this approach? We have started recently a collaboration with the University of Massachusetts gene therapy group, and we're planning a pre-IND application to FDA for the intravenous treatment of PMLD1 patients. This is also based on the already approved protocol that is used by ASPA Therapeutics in a clinical trial for Canavan disease. So this is an intravenously delivered vector for gene replacement in Canavan disease, and is used for patients up to 30 months of age, because we know that in these young children, the blood-brain barrier is still permissive to systemically deliver gene therapies, and so we can hope to have adequate targeting of the brain for the gene replacement, also for PMLD1. But we also look for alternative delivery approaches that will be useful for children older and beyond 30 months of age, when we no longer have the option of intravenous delivery. So in order to do that, we looked at the developments that currently occur for other leukodystrophies, and we started the discussion with Myrtel, which develops currently a gene replacement therapy, again for Canavan disease, using a viral vector capsid OLIC001 that is used for replacing the ASPA gene. And this is delivered by intracerebroventricular injection. It's already in a phase 1/2 open label study with encouraging results, and is approved for children up to 60 months of age. So here we have a bigger therapeutic window. And so we started a collaboration with Myrtel to test the OLIC001, which has a tropism for oligodendrocytes, in order to deliver the gene therapy for PMLD1 using our therapeutic plasmid. And this we will test in P10 and P20 mouse model of the disease. So this project has just started. I would like to thank Ella for funding this project. So the aims is, first of all, to test the biodistribution and expression of oligodendrocyte-targeted OLIC001 gene therapy that delivers the human connexin 47 gene. We will first test this vector in the connexin 47 knockout mouse and examine the expression in oligodendrocytes using this delivery method by injecting in the cerebral ventricles. And we will examine the expression at different time points, both with the therapeutic and the reporter gene vector, in order to confirm that we get adequate targeting of oligodendrocytes throughout the CNS. And in AIM2, we will perform a treatment trial in the double knockout model of the disease. And here we will compare the therapeutic with the control vector and examine again the same outcomes, behavioral, testing, survival, morphology, inflammation, but we will also look for biomarkers, which is something we don't have until today established for PMLD1. And this is in collaboration with a group of Professor Bertini in Rome. So we will check also NAAA and NAAG substances in the brain, and also some inflammatory and ferroptosis pathways by RT-PCR. And so I close here with a summary of where we stand with PMLD1. So we have done preclinical work using different approaches that may be suitable for different groups of patients. We have proof of concept for AAV9 based intravenous gene replacement therapy targeting oligodendrocytes. We are currently now just starting the intracerebroventricular approach using the OLIG-001 capsid in collaboration with Myrtel. We're trying to establish disease biomarkers in the mouse model, and we are planning pre-IND application for the intravenous approach, hopefully in the next 3 months. Of course, the pathway to the clinic is still long. We also need biodistribution in the CNS, oligodendrocyte targeting demonstration, and safety toxicity evaluation, probably in larger animals, perhaps non-human primates. And definitely we need collaboration with industry because this is a very rare disease that has not attracted significant interest so far by industry. So we try to use already established platforms that are currently in clinical trials for other leukodystrophies. And I believe this is the way forward for the very rare leukodystrophy types. And I want to emphasize before I close that it is very important the role of patients and patients associations. And we need to expand at the international level, especially for the ultra-rare leukodystrophy forms. We do not have currently a natural history study, but I know patient registry is in development. Thank you to Adeline and also Nicole. I know that you're trying to develop a registry for PMLD, and this is very important, obviously, for any future clinical development. And of course, we need biomarkers and clinical outcome measures. And so I hope that we can all work together in a global consortium from the preclinical all the way to the clinical aspects in order to make progress for this disease. I would like to thank you. I would like to especially thank Elena Georgiou in my lab, who has done most of the work that I have shown from my lab, and all my group. Also the group from Rome, Professor Bertini, Fiorella Piemonte, and Francesco Nicita for collaborating with us. I would like to thank Richard Layer from Myrtel, who is helping us right now for the new approach. I would like to thank the Piccolo Grande Guerriero in Turin. They really did a great job to support our work for the past few years, motivated to help their little Simone. And I would like to thank also PMD Foundation and of course the ELA for supporting our research throughout this pathway in the last 10 years. Thank you again.
Kleopas, thank you so much. That was lovely. We're going to move into our last talk before our question and answer session by Vivi Heine. Vivi is a professor at the Amsterdam UMC who has a bench laboratory whose goal is to identify and describe glial defects and use iPSCs for proof of concept studies for glial targeted therapy. Thank you, Vivi.
Thank you for the nice introduction. I think you can see my screen and hear me. I
Yes,
hope.
it's perfect.
Great.
Thank you.
Thank you so much. And thank you for giving me the opportunity to present. I'm always happy to be here and give an insight in the research we are doing. On the contrary of the other talks, we're still very much in the preclinical phase, but of course we are aiming for supporting eventually the development of new treatment strategies. My talk will focus around the use of human stem cell-based model systems. So sometimes there are no animal models, or for other reasons, it's wished that we are starting to use more human-based model systems. It could also be that human tissue is scarce, so we have not the opportunity to study patient tissue. And it could also be that animal models are not fully replicating the human disease, and that we are looking for opportunities to have human cells in our preclinical setting to study the defects in the patients. And and maybe it's also good to mention that the human brain has a very high content of brain white matter, and that is quite different from the rodent models that we are quite often using. So I will focus on using and explaining the induced pluripotent stem cell technology, because nowadays we have the opportunity to take cells from humans, from patients, from every individual actually, blood cells or skin cells, and we can reprogram these mature cells to a very immature stem cell state, that they have still the opportunity, still the capabilities of embryonic stem cells, and those cells can still differentiate in a cell culture dish to every specialized cell of our body, including brain cells. And this technology is really evolved in recent years enormously, and the protocols also to generate different brain cells really involved. So we now can generate different types of brain cells from different types of neurons, glia cells, oligodendrocytes, astrocytes, and also in recent years there has been an enormous investment in creating microglia cells. We can create those cells by themselves, so let's say a pure neuronal culture in a cell culture dish, but also the protocols to have kind of co-cultures that you mix neurons with different glia cells, for example, neurons with oligodendrocytes. Those protocols are improving, but also in recent years, the protocols to generate more complex three-dimensional structures really evolved. And the names are brain organoids, brain spheroids. People even create assembloids, so they have different type of organoid structures that they are fusing together. So, and the difference of these organoid structures from more the simplistic monocultures is that when you have these early embryonic stem cell-like cells, that you are pushing the cells into these three-dimensional structures that are able to create kind of spontaneously, but we are pushing them a little bit in a certain direction, that they are generating both neurons and glia cells next to each other. So they also have the opportunity to influence each other while the structure is developing in cell culture. And especially we think for the leukodystrophies, where we see that both neurons and glia cells are so much interacting in brain white matter, it is important to have both those cell types present in our disease model. And here you can see, so we have been using the protocol that's developed by Marton et al. In the Pasha lab, and we can keep these organoid structures for actually quite a long times. People even keep them for months, and we really see that those structures able to generate different neurons and glia cells, and also oligodendrocyte and white matter structures. So, as part of a consortium, a European consortium, we wanted to take our expertise together from the leukodystrophy field, but also from the stem cell field, and create a platform to study different type of organoid structures that we have generated from different patient cells. And this was in collaboration with Oliver Brussler in Bonn, Angela Critti in Milan. They really also contributed a lot of stem cell technology and also collaborators in France and in Porto, but they contributed less for the work that I'm presenting now. The three leukodystrophies that we focus on in this initial phase are 4H leukodystrophy, globate cell leukodystrophy, hypomyelination, and Canavan disease. And Nicole Wolf gave a fantastic introduction already to the different leukodystrophies. Maybe it's good to mention that all these leukodystrophies have a different genetic cause, and 4H leukodystrophy is a hypomyelinating disorder. So already during development, the myelin is not structured well, while Canavan disease and GLD are so-called demyelinating disorders. So first the myelin is present, and later on the myelin is being affected by the genetic cause. So we collected cells from patients from these different disorders, and we generated IPCs from these patients, but also from healthy individuals. And from all these patients and healthy donors, we had IPCs, and we also created these brain organoids via these established protocols. And maybe it's good to say once again, because no, I'm just going to mention it again, and maybe to clarify it also a little bit later on. So these organoid structures, they have a lot of different cell types present. And like I said, oligodendrocytes, astrocytes, and different types of neurons, but also still cells in an early progenitor stage. So that is quite typical for these organoid structures, that you see quite some early progenitors still present, while you also see mature cells being formed. But that does give us the opportunity to study developmental maturation processes of these different cell types in a diseased background. So we generate these organoid structures, and we really wanted to know, do we actually have organoid structures from the healthy individuals and also from these patients that are also representing the different cell types. So we kept these organoid structures for quite a few days, and we collected them at different time points, at day 50, day 100, and day 150 for so-called immunocytochemistry. So we fix the cells, we make very thin slices, and with the use of antibodies, we are able to visualize specific proteins in the organoid structures. And we did also single-cell RNA sequencing, and I will come back to that later on. But what we did during the culturing, we have been measuring the size of the organoid structures. And we could see that the organoid structures there were definitely variability, but overall they were quite homogeneous, although we saw that the size of the organoid structures from 4H and GLD were slightly smaller in size than the organoid structures that we generated from healthy donors and from Canavan diseased patients. And we need to see whether that also has a base in the disease or a genetic cause. So the diameter measurements, that's what I'm showing in the left panel. And then the first days, the first 36 days when we are given growth factors, you can see the cells are proliferating a lot. So the structure is actually growing really in size. So there you see a very steep line going up. And at a certain point, we are reducing the number of growth factors. So we want to stimulate those cells to really mature into more adult cells. And then you, from day 50 on, you see that it is stabilizing. On the right side of this slide, you can see some examples of the immunocytochemistry that we did. GFAP, which is in the top part, that is able to recognize astrocytic lineage cells. NF stands for neurofilament. Those are typically recognizing the neuronal populations. And in the bottom, you see OLIC2 and MBP. OLIC2 is recognizing the oligodendrocytes, and MBP is myelin basic protein. And if oligodendrocytes are also MBP positive, it means that the cells are maturing. So we have a good start. The cells have been growing, the organoids have been growing to a good size, and we can see that the different types of neurons and glia cells were present. And we were also very happy to see when we used electron microscopy, which gives us the opportunity to study way more in detail the structure of these organoids and also the cells. We could see the rings. I hope you can recognize those rings. Those are typical myelin structures around the axons. So it's not that the oligodendrocytes are only maturing, they actually start to generate myelin wraps around the axons. So that is really, and that was encouraging for us that we could study white matter structures and also defects in the patient's cells. So that was our base. And what we then decided to do, and I will, from now on, I will focus a little bit on this analysis, which is quite technical, but hopefully I'm able to give insights in the kind of analysis that we are doing on these complex brain organoid structures, but also a lot of other labs are using this technology to study in detail how different cell types are developing and how the genetics of the patients are influencing the development of different cell types. So the idea is of single-cell RNA sequencing is that we're not taking the complete organoid structure and then put it all together and look at the expression of the different genes, but we first make or take apart or dissociate the organoid structure, all the single cells. We barcode all these single cells so we can recognize them later on back, and that we create a expression profile from every single cell. So that's in really an advancement in this expression field that we now really are able to study the expression profile from every cell in an organoid structure. That can also, of course, be done for the human brain, and that is also being done, but I focus here on how we applied it to studying the brain organoid structures. And what people do is creating these typical UMAPs. And I can imagine if this is the first time you see it, that it is a little bit of an awkward new image, if you see here on the left. And this is typically a UMAP, and every dot is one single cell. And and as I said, every cell created, we created a gene expression profile. And with this UMAP, what we are showing is if the expression profile is closer to the expression profile of another cell, then we are putting it close to each other. And when the expression profile is really different, then it's at the other end in the graph. So maybe you also can see if you have multiple cells that are actually the same cell type, they are clustered together. And we even gave a color to it that you can actually see, hey, based on the expression profile and how it's spontaneous cluster, we think that all these cells actually are the same cell type in the brain. And in this way, we were able to identify 27 different types of clusters that we say that based on their expression and how they cluster, they are representing a different cell type that you find in the brain. And what I said before, those are clusters of cells that are more immature or more mature. And on the right side here of these slides, you see at the bottom, again, those different cell types that we labeled. And we also checked, okay, we think that this cluster is, for example, the mature oligodendrocytes. And then we looked into the expression profile and then indeed saw, yes, indeed, MBP, as we expect, for example, is highly expressed. So that's a little bit how we look in the beginning at this single cell RNA sequencing data and making these, let's say, UMaps and this in getting these different clusters that is based on known knowledge and also this random clustering that is happening when we look at the cells and the expression profile. And it takes actually quite some time before we had these maps and before we actually really can dive into the details, because this is only what you're seeing from the healthy donors. And next to that, we not only took one time point, but we collected the organoids and did single cell RNA sequencing at day 100 and day 150. So we could even study from the same patient line how those different clusters evolve and develop over time. And on the right side, you can see that over time, you indeed also see that the immature cells are decreasing and the number of the more mature cells, as you would expect, are increasing over time. And that's a way how we could look at these cell types and how that's also different between the organoids that we generated from the healthy donors and also from the patient cells. To bring it a little bit to another technical level, what we also could do is the pseudo time analysis, so that we even could say like, well, there are a lot of immature cells, more mature cells. We look at the time, so we can now reconstruct a little bit how we think that the oligodendrocytes, astrocytes, and neurons have been developing over time from a more immature state to a more mature state. And then you're able to create these kinds of graphs. For example, here on the left, here in the top, in the dark, you have them for all the different graphs. You see the very immature cells, but at a certain point, the cells decide to become astrocytes or oligodendrocytes, and then they are walking a different path towards the other cells that we also have collected. So this is again from the healthy donors. And if we create also these maps from the patient cells, you could in a way maybe imagine that if the path or this wave is different for certain patient cells, that you say like, hey, there's maybe something going on in the astrocyte or the neuronal development for that particular cell type in that disease. And maybe that gives then a starting point to study it more in detail. So these are another way of studying this RNA sequencing data. What we also did, and again on the bottom, you see those 27 clusters present. And we also really want to know, because for these leukodystrophies, we very well know what the disease genes are. And we also want to know whether those genes are actually being expressed in our organoid structures if we want to model this properly. And so we selected, for example, ASAH1 and GAL-C, which are important genes and really we think are important for GLD disease. And it's in confirming, so you see when it's red, it's more highly expressed. And you can see here the dots are a little bit more red, so the expression is higher in these cell types that are depicted here at the bottom, and that's confirming what we already know in astrocytes, immature astrocytes, ependymal cells, than if we compare it to some of the neuronal cells. So this is another way of looking at the data and checking, are we having good representative models to study our disease? So this was a lot about what I just presented on the healthy donor organoid structures. But now we have the opportunity to say, like, well, okay, let's start comparing them. I already showed you this UMAP of the healthy donors before, and I only shown the 4H and the Canavan disease, but we also have it from GLD, but it just did not fit here in the slide. But I think 4H and Canavan is already illustrating of what I want to show, because you have those different populations present. And what we, for example, saw is that the cycling radioglial cells that are present in the healthy donors were absent actually in 4H Canavan and also in the GLD organoid structures. And so we also looked for the different cell types and how those are maybe less prevalent in the diseased organoid structures versus the donor structures. So this is one way of checking, hey, what are the cell types that we need to study more in detail and look at the expression profile and could say something about the disease mechanisms. And again, because you have an organoid structures with so many different cell types, you immediately study it on a broad level. We also can look at it in a little bit more of a quantitative way. So we can take out specific genes of interest and then see how those genes are expressed in the different organoid structures. And I wanted to show you these two examples. GFAP are, that is a marker that is highly present, for example, in the glial progenitors, also in a certain more mature astrocytic stage, I have to say. This is collected at day 150. And what we thought is very striking, and we're going to follow up further, is that for the 3 different leukodystrophies, we see that the expression of GFAP, so indicating there are more glial progenitor cells in the leukodystrophies than when you compare it to the healthy donor organoid structures. And also what we saw is that MPP, which is labeling the mature oligodendrocytes, that marker is lower in the organoids that we generated from Canavan disease and 4H, indicating that the myelination processes in these diseased organoid structures are decreased versus if you compare it to the healthy donors and the GLD. And so you can study a lot of different genes. So this is on the gene level, but and there are of course a lot of different genes that you could study and take out, but we also have the opportunity, and over time the fields have generated what we so-called gene pathway analysis, so we can actually combine the expression of different genes, and we can see to what extent they influence each other. Sorry, that is the gene enrichment analysis that I'll show you in a bit. This is sorry, it's so confusing. This is the differential express analysis that I'm showing you now. And that is typically shown in these volcano plots. And here, if you look at the first panel, there you see those blue dots that are going up. And then on the left, you have the red dots that are going up. And every dot is one gene. And we're only looking at here as one of the 27 clusters, which is what we labeled OPCs for GLD versus healthy disease patients. healthy donors. And then we looked at what genes are upregulated. So those are the dots here in blue. And what are the genes that are downregulated? And those are the dots here in red. And this is just showing for the oligodendrocyte lineage cells. So these are 3 clusters, the OPCs, proliferating OPCs, and the oligodendrocytes. But there are 23 other graphs like this for the GLD, the 4H, and the Vanderver disease. So there's a lot of data. And here you can just look in the different cells, cell population, what genes are dysregulated in the upper direction and the lower direction. And here with some red circles, I'm showing some genes that we are following up, that we are interested in because they are, for example, downregulated in different cell types, or they are related to the disease mechanisms that it's involved in, or we see certain disease-specific changes or some changes that are present in all leukodystrophies versus the healthy donors. So we are still studying it on every level, and this is even on day 150, but we also have all these graphs and analysis at day 100. And I started to confuse you because I already was start talking about the gene set enrichment analysis, because I want to say that you can study everything on the gene level, but we also have the opportunity to study different genes at the same time and look at a pathway, because there are different genes related to a pathway. And that is what you could also see if there are several genes belonging to one pathway that are dysregulated, then you're reducing, in a way, your bias a little bit, and you get more insight in what kind of mechanisms could be involved in the different cell types. And this is one example of one of those graphs that you're getting. So on the left, you see this long list of different pathways, let's say cellular response to chemical stress, cycling, or other kind of mechanisms that is not on the gene level, but more on the pathway level. And then again, we can study that on day 100 and day 150. And we also have that, what I just showed, I think that it was in front, but I think I just showed you, for Vanderver disease, and these are for 4H disease. So we can actually study how those different pathways are dysregulated at different time points, also in the different 27 clusters, and we can even compare the different leukodystrophies with each other. So we are still in the process to understand better, and we also feel that it is really important to now include more patient lines to really confirm the data, so that we really know that what we are seeing. So 2 more slides to conclude. So our spheroids or organoid structures, there are different names in this case for the same thing. We see that the organoid structures are able to replicate disease-relevant cell types, and that we can use single-cell RNA sequencing to look at the different cell population and maturation to get more insights. And I gave you some insight in the differential gene expression analysis and also the gene pathway analysis, how you can study how there are molecular and cellular changes ongoing that are caused by the disease genetics. And we're also looking into some shared pathways, maybe that can help us to search for new therapeutic targets. So what is important is also to see now, because this is studied at the gene expression analysis, but we really also want to see if the those gene expression changes also translate to cellular dysfunction. So for that, we need functional validation studies. And of course, we really want to start using these organoid structures in the end as a model system to start testing different therapeutic interventions to see whether we can normalize certain molecular and cellular changes, which we could further develop towards more therapeutic targets. And we're finding our model systems, that's what we're still constantly doing in this stem cell field. And of course, I really I want to thank the team, because this is a big team, the consortium, the different younger and more senior researchers at the different institutes within the Netherlands. I really would like to mention Lisa Kok, who did actually a lot of the cell culture work in the Netherlands. Nicole have been always a very big support of our studies, and of course is seeing the 4A leukodystrophy patients. And we are funded by the European Joint Program, so I thank that. And of course, Ila, who has a great partner in our studies, and always in supporting our research. Thank you for your attention, and if there are questions, I'm looking forward to them. Thank you so much.
Thank you, Vivi. At this point, I'd love it if all our panelists, maybe excluding Nicole if she's not feeling well, would be kind enough to show their pictures. Perfect. And as a reminder to everybody, you will be able to either post your questions in the chat, or turn on your audio and ask them in any language you pick. There are wonderful interpreters who are standing by to provide interpretation. And I think for the panelists, I think the request is that you answer in English and then let the interpreters translate. I've understood everything correctly.
Yeah. So yeah. We do have some question in the chat, and then we have a first question in oral. So we're gonna take the oral question, and please ask your question in oral more than in the little chat, because it's easier for us. Thank you very much. No, she left. Yeah. There is no more hands up. Okay, so. Okay.
Maybe while we're waiting for other people to ask questions, I'll ask one that I think might be relevant to the patients. We sort of talked about a lot of potential therapeutic options. What's your sense of the timelines, right? You know, as far as what can patient families expect for these sort of gene and antisense therapies? You know, of course, in PMD, some of them are already in patients, but what's the typical timeline for some of these delivery to be in a clinical setting where they might be accessible to patients? Nicole or Steffi, since you're both involved in clinical trials.
Yeah, I can say something about that, and also replying to the question about HEMS, which is a special form of Pelizaeus-Merzbacher disease with intronic variants. So one thing is to develop a good antisense oligonucleotide and also produce that in sufficient quantity. The other thing, which is certainly in the slowly progressive disorders as HEMS, very difficult, is to know whether that treatment works. And for that, we had already quite some discussions, because what are good outcome parameters, and how can we actually tell that that treatment is effective in patients? Probably also depends on the age of the patient and so on. And this is not an easy question, and that can actually take quite some time. So years, I'm afraid, yeah.
Yes, years, definitely. For the PMD, I think it depends where you want to put the starting point. So as it got with these Nature publication and that feasibility trial readiness, to put it that way, as that sort of took shape from there on, I think it took another 4 years, 3 years, 4 years before it actually got running and the site initiated. And well, now over the last couple of months, the first ASOs actually applied for the PMD trial. Yeah.
Someone's asking a question about when clinical trials will start in TUBB4A. Maybe I'll take that one, right? My understanding is that there's a company called Enlorem who's doing some compassionate use application of antisense trial in TUBB4A, but they've only treated 1 or 2 patients. And the way they're doing it will mean that they'll be limited to just a very few patients. It's sort of a preliminary to a clinical trial. And then there's another company, Synaptics Bio, that has a different antisense that's European-based, and that has not yet announced a clinical trial start date, but are actively planning one, and where the sort of expectation is within the next year or so that they will start a clinical trial. And then there's a question for Dr. Kleopas, but I can't
I
understand
can
it.
understand. Adeline,
Okay.
yes, I know. They're asking what is the future possibility for treatment in 10-year-old or older children with PMLD1. So, as I said, for the intravenous delivery, we're really restricted to infancy just because of the blood-brain barrier. But first of all, in the future, we may have viral capsids that may be more blood-brain barrier penetrant. There is a lot of research going on in this area, so we may have more options also with systemic delivery in the future. But the intracerebroventricular delivery, I believe, could be effective also in older children. I don't think that necessarily the restriction of age currently used in the Canavan trial must apply. It remains to be seen. So I think we have to see for older patients, but the answer is we don't know because it has not been used so far in humans. So.
Thank you very much, all of you. We are a little bit running late, so we are gonna open a breakout room now. So this year we just would like to try something for the audience, to open a breakout room on Zoom. So it's a room where you can join and discuss directly with the scientists by turning on your camera and your microphone, like a classical online meeting. And so due to technical restrictions, the room is open only in English, and there will be no translation there. And the breakout room will be open around 30 minutes. So if you want to join us, click on the breakout room in the Zoom toolbar and join the room. This room is called Breakout Room PMD. And if you have some issue to join, just raise your hands up and then we will send you there. So see you there. And then for those who will not join the room, the meeting is closed. And so thank you very much to all viewers, speakers, chairman and chairwoman, and all interpreters to be with us today. We hope you enjoyed the great quality of all the presentations. And we will be back tomorrow at 2 p.m. So we wish you a great end of the day. See you in the breakout room for the others.
Thank you.
Thank you. Bye.
Thank you.